and 20 NMC allocated medical colleges. Resource, she has been a resource faculty for more than 75 which approved MET, ESSET and RMW workshops. She is the executive committee member for Maharashtra IAPSM Governing Council. She is a member of Institutional Ethical Committee. She is also a chairperson at National IAPSM Conference held at Nagpur, Tribal National Conference 2020, NCHPE 2023. She is also presented papers and posters in various international conventions and various research competitions. She is having a first prize in that particular competition, National Public Health India Conference. She is a faculty at pre-conference workshop, NCHP 2023. She has been organizing secretary for National Conclave. More than 50 national and international publications to her credit. She has been a peer reviewer in Journal of Clinical Diagnostic Research, JCDR. So, more than that, she is being a part and parcel of this SIP program. Those students who had joined under the Department of MET. So, Madam is constant support to that particular MET section. Also, she is very enthusiastic and giving her new ideas to her IR department as well. So, with this, I welcome ma'am, and I also request ma'am to please continue with the session as I am having a second meeting that is related to our COE. I might be going to attend that meeting. So Pratibha madam will be here and she will take on. So over to you, Pratibha madam, please. Over to you, Supriya ma'am. Please continue.
Yes. Thank you so much, Rathod sir, for that kind introduction. A very good afternoon to one and all. And at the outset, I express my sincere gratitude to Honorable VC Madam and all the office bearers, respected office bearers of MUHS Nasik. And my sincere thanks to Dr. Sandeep Rathod sir for giving me this opportunity to connect with all you enthusiastic SIP students. So as you all know, SIP is a multidisciplinary program. So we actually, as MUHS, cater to students from all health sciences. So when it came to the choice of topic, then we have to think of something that applies to all. And you be from any pathy, any faculty, medicine, dental, Ayurveda, nursing, physiotherapy, anything. Finally, we all are part of healthcare team. You all are the future public healthcare experts for our nation. And hence I thought, why not give you a brief overview of evolution of public health in India. Pratibha madam, I have started sharing my screen. Please confirm whether it is visible.
Yes, ma'am. This is visible.
Okay, and is the slide changing?
Yes, yes.
It's changing, right?
All okay, ma'am.
Yeah. So that's why I thought, why not give an overview of how we evolved the public healthcare system of India right from the British era till this digital era. So with that, let's begin. First of all, what exactly do you mean by public health? So there are book definitions of public health given by organizations like World Health Organization or CDC Atlanta. Both, if you read, they are similar to each other. So public health is all the organized measures to prevent disease, promote health and prolong life among population as a whole. When you read this carefully, nowhere it says that public health is about giving cure or treatment to one single patient. So when a physician is sitting in his OPD and let's say treating a patient of dengue, that's his private practice. However, as a public health experts, when the experts are sitting and jotting down the preventive measures of what can be done to prevent the dengue outbreak in the community, what are the pre-monsoon measures to be taken, what are the health education measures to be taken. So now we are talking about public health. So the focus of public health is on entire population. It is never on individual patient or individual disease. So it is the science of protecting and improving the health of people and their communities. It has a larger perspective than one-to-one physician seeing one patient. Okay. So as we said, it doesn't comprise only of curative part of the health. So it consists of disease prevention, health promotion, screening, early diagnosis and prompt treatment, and finally going down the spectrum to disability limitation and rehabilitation as well. Now, why do we need this public healthcare system? Say if we fall ill, if any of our family member falls ill, we all being from, let's say, a background where one can afford going to a private practitioner. So we are kind of sitting in those ivory towers. But if we look at the rural situation, India's 3/4 population, they say, is in rural areas. We are the most populous country. So who's looking after their health? So that's where our public healthcare system comes to play an important role. Above all, we are said to be the youngest country. Our average age is somewhere around 30. So we have the highest potential to become developed nation, and we are planning to do so, Vikasit Bharat at 2047. But whom do they really call a developed nation? They label it based on what is your GDP, the income, per capita income, gross domestic income of that country, or literacy. Sorry, was I muted? Pratibha madam,
Yes, ma'am.
was I muted?
No, ma'am. आवाज येतोय तुमचा आता?
नाही, आता येतोय.
हा. नाही, फक्त 2 सेकंदासाठी बंद झाला होता. बाकी येतोय आवाज.
ओके ओके ओके.
या कंटिन्यू करू शकता तुम्ही.
So, yes, so we are the youngest country with a potential to become a developed nation, Vikasit Bharat at 2047. What exactly will make us a Vikasit Bharat or developed nation? As I was saying, it is not our GDP, it is not our domestic income, it is not the per capita income, it is not the, salary, the employment, the industrialization or literacy. One parameter, can the participants please mute themselves? Yeah, Dr. Rishikesh Meshram, can you please mute yourself? So one parameter, if they say, define the developed country is infant mortality rate. So my point of telling you this is developed nation parameters are not the physical parameters, but they are always the healthcare indicators. So the health of the people is the foundation upon which all their happiness and all their powers of the state depend. Because healthy nation, healthy people will give rise to more workforce, more productivity, and finally a developed nation. So it is all interlinked, right? So if we say that public healthcare system is needed, whose responsibility is it to provide this public health? So obviously there is a hierarchy. Government, the central government allocates funds, decides budget. However, when it comes to implementation and actual delivery of the public healthcare system, the responsibility is given to the individual states. Please remember this. So this is a hierarchy or organogram of central government where most of the decision making, policy making, budget allocation is happening. They will set the programs, they will allocate the budgets, the implementation will be taken care by the state governments. Okay, so what exactly is the role of government? It's a very crucial aspects of a nation's well-being, the public health. So role of government in ensuring the health and welfare of its citizens is very important, and it is multifaceted. I have written it down. Let's not go into the details, but it is multifaceted, means right from policy formulation, establishing guidelines for the disease prevention. If you go to the site of MOHFW, the Ministry of Health and Family Welfare of India, mohfw.gov.in, or if we are all from Maharashtra, we have mahaarogya.com. So on those sites, you will see that there are guidelines for every disease. So there are national guidelines for malaria, national guidelines for dengue. So establishing these guidelines centrally is the job of the government. Allocates resources and funds, of course, Parallelly, it enforces regulation on food safety, water quality, sanitation, because these all are finally the determinants of health. Okay, it undertakes preventive measures during health emergencies. We all have seen the paramount role of government when we face the COVID pandemic. And it also launches awareness campaigns to educate the public about the diseases. So you will always see during the pre-monsoon era, they will come up with those advertisements about, observing dry days and how to get rid of the mosquito breeding places, etc. Also campaigns about substance abuse. Even if we go to watch a movie in the theaters, we see that there is an ad coming regarding cigarette smoking. So all these things, these awareness campaigns. So these are not curative. Are they curing any patient? No. But this is public health where we are talking about prevention and health promotion. Okay, so this was an overview of public health. But it is in today's era that we are talking all these things. How did we evolve? Okay, so for all of you who had history as their favorite subject in school would probably like the next few slides. For those who did not like history, I'm sorry, but when you are going to become a doctor and when you are going to become a part of healthcare system of our country, it is our job to learn the history because there are a lot of lessons to be learned from the history. So this is the map of colonial India in the British pre-independence era. If we go back, the British East India Company entered somewhere in the 16th century and they brought along their own medical officers to take care of their company employees only. They also established a hospital, Madras Hospital, which was the first modern medicine hospital in India. Then there was Presidency General Hospital in Calcutta. Then there were civil and military services that they established in 1757. So long, they were still, catering to the medical services of the troops. So they have still not come down to catering to the medical services of civil people or our general population, right? So the first teaching institute of Western medicine in Asia was actually established in 1835, and it was after the, you all must be remembering the 1857 war, okay, in Marathi, 1857 चा उठाव, which was there in our the fight for independence. So after that 1857 war, the rights were put forward and fought for them, and that is how in 1868, finally a separate civil medical department was established in Bengal, which then catered the needs of common population. Finally, in 1919, by these constitutional reforms, all the vital statistics and public health responsibilities were transferred to states. Okay, so this was the first example of decentralization. If you remember a few slides back, I told you that it is the responsibility of state, but it's there since 1919. These are the few photographs of first few colleges. So this is the Kolkata Medical College or Bengal Medical College of 1835. Similarly, this is Madras Medical College of 1835. Okay. In 1854, the government of India, now when I say government of India, it was still under the rule of British. So they agreed to supply medicines and instruments because there were these hospitals and dispensaries started growing finally. So the drug depots were established. Finally, they also catered to the mental health. That time they called them unit asylums. Okay. Nowadays we use this word as a slang, right? Lunatic. But that time it was used as a scientific word, central unit asylums. They were established at 4 or 5 places. Finally, by 1902 in India, there were 2,500 public hospitals and dispensaries. And thanks to our all-time record of population, but the patient turnover was also to the record of 22 millions. Right? So far, as I said, while they were catering to their own troops, the British officers were treating only the British troops, their army people, their British East India employees, etc. What they observed was that the mortality rate among these troops was very high, 69 per thousand. Why was this? Because till then, the era of sanitation was not there. So the conditions were so bad that not even 3% of the Indians had their own personal latrines. So there was a Royal Commission report which they brought about in 1863, which told the sanitary conditions of the army. And then they thought of establishing a public health commission in each presidency. And what did they recommend? That there is a need to improve sanitation and prevention of epidemics in civil society. Then only the health of British Army will be good, because all communicable diseases they're contagious. So unless you treat all, the outbreaks are not going to stop. Okay, so they actually established a sanitary police force. So there were sanitary commissioners, there were sanitary inspectors who were responsible for inspection of sanitation, supervision of vaccinations, vital statistics, etc. And finally, what they did is, because centrally it was not possible to look after these things, the sanitation part, the vaccination part, etc., the vital statistics. Hence, it was decentralized and it was given to local self-government. So, if you know the India's local self-government, it is right till the level of village Gram Panchayat. And this happened in 1885. And today in 2024 also, we have something called as Village Health, Nutrition and Sanitation Committee. So the role of that committee is same, which was given in 1885. Okay, health, sanitation and nutrition. Moving ahead, once the sanitation was achieved, the infectious disease was still a challenge. And now was the time when the smallpox vaccine was getting discovered. It was the first vaccine. It was getting discovered, and that is how there was Superintendent General of Vaccination was appointed, who would look after the smallpox vaccinations as well as the childhood vaccinations. So as they progressed, by 1902, the successful vaccinations at birth, which we now call routine childhood immunization program or universal immunization program. Today we have very high coverage of immunization, but in 1902, they still could reach a percent of 39.1. While they were doing all this, the British, they also faced a lot of challenges. The challenges were of endemic diseases which were new to them. So when a British person used to travel from there to here, malaria was something, let's say, which was endemic to our country. So they were not immune to it. So they used to suffer. Today also, if a person from a country where malaria is eliminated travels to a malaria endemic country like us, they have to take chemoprophylaxis, which was not existing that time. Another challenge was our country it's a vast country with a lot of geographical, cultural and climate diversity, giving rise to different patterns of the diseases. Resources were of course limited. And apart from these endemic diseases, there were outbreaks of these terrifying illnesses, infectious diseases like plague, leprosy, cholera, malaria. Okay. There was nothing like a private sector organization that time. Environmental sanitation was being neglected. All the target was on curative services. Why? Because so many people were suffering that whatever health resources were available, they all used to go into curing these diseased people. So there were hardly any resources, manpower and infrastructure and funds left for thinking and utilizing for prevention. So in the late 19th century, the government realized that so many deaths can actually be prevented. We could strengthen the public health system. Okay. In spite of these challenges, during the pre-independence era, there were few good things that happened in the public health as milestones. In 1873, they passed the Birth and Death Registration Act, which is still valid. Of course, the period to which death or birth can be registered has undergone an amendment, but the act still exists. The Indian Factories Act again has undergone amendments, but it still exists. And first All India Census was held. This is something that really British did for us. First All India Census, and since then it is getting continued every 10 years. So 1881 was first, then was 1901. ऐसे करते करते 2011 तक we had a regular Indian census. 2021 India missed its all India census because of the COVID pandemic. However, there are other National Family Health Survey or sample registration surveys which are going on. And another thing that happened during the pre-independence era was to control the epidemics, they appointed special officers, committees, and commissions. One of such committee was Bohr Committee under the chairmanship of Sir Joseph Bohr. Now, finally, we come to the just pre-independence, that is 1946. So 1943, in fact, was the time when Bohr Committee was constituted, and they gave their report in 1946. So this report was one of the reforms which led to the evolution of public health system of India. And another reform which helped us to evolve was the emergence of modern medical technology for prevention and control of specially communicable diseases. Which modern medical technology are we talking about here? In the late 19th century, so this is the discovery of antibiotics and discovery of vaccines, due to which we could get control on the pandemic potential communicable diseases. If we go back to the Bohr Committee, they recommended certain remodeling of health services. So what did Bohr Committee say? They were so visionary that they told the comprehensive model of integrating preventive and curative health services at all levels. Hospital-based healthcare system. They also suggested that primary healthcare centers, the PHCs, which we see today, all thanks to Joseph Bohr Committee. So the PHC's establishment was suggested by them. They also suggested the population norms. So not completely, but Bohr Committee's recommendations were partially accepted, and which were accepted that there will be one primary health center per 30,000 population, which still exists this now. 6 beds in primary health care. There could be even more, but this is minimum. Now only one doctor and truncated paramedical staff. So scarcity of human manpower in rural areas is still a challenge. After the Bohr Committee came many such committees like Mudaliar Committee and Chadda Committee and Mukherjee Jangalwala. All of them gave their own observations and suggestions. Most of them underline the importance of primary healthcare centers so that the health of the people, the healthcare is accessible to people, affordable to people, acceptable by people. It is right at their door. Okay. Some committees gave the advices regarding malaria, family planning program, etc. There was a Bajaj committee which also gave very important recommendations that we should have a national health policy and we should have a health science university in various states. Okay. Maybe as NUHS, we should thank back then Bajaj committee has recommended that every state should have its own health science university. Okay. So now the independent India from 1947 started their 5-yearly plans. So as you know, until the Niti Aayog was established in the recent years, we always had 5-yearly plans. In Marathi, they were called Panchavarshik Yojana. So in every 5-yearly plans, because health planning also was an integral part, because no socio-economic development is possible unless we plan for health. So in every 5-yearly plan, they will give some budget, some planning for healthcare as well. Now, when we look at one of the statements from Bohr Committee, what they said was, if a nation's health is to be built, the health program should be developed on the foundation of preventive health. And such activities should proceed side by side with treatment. So they said 2 things, that you should have a national health program for every disease. Second, that national health program will not only give guidelines ki okay, agar dengue hota hai, complicated, uncomplicated, what should be the treatment? No, it will cater to preventive health work in parallel to the curative part, right? That is how many national health programs were born. Now, there could be 2-hour session on each program, but this is just an overview of how it is evolving. So, after the Bohr Committee recommended national health programs, The first national health program, in fact, was National Malaria Control Program. And it is very interesting that it was announced as National Malaria Control Program. And in the first 5 years, because of the rigorous efforts, and they focused on DDT spraying, and the malaria prevalence went down almost by 70%. And this gave such a boost to the entire health system that they renamed it as National Malaria Eradication Program. Okay, so this happened in 1953. And imagine, again, 2024, we still have not eradicated malaria. What went wrong? So what they did in the first program of malaria was they focused on DDT spraying only. And then first 5 years, the mosquitoes responded to DDT. That's why malaria prevalence suddenly came down. But after that, there was no similar response because they relied only on one strategy. And next programs in malaria were modified to have integrated vector management along with treatment. So that is how the various national health programs were established and evolved. So they can be classified as communicable disease programs, non-communicable, national health programs related to nutrition, environmental sanitation, specific to maternal, reproductive child health programs. Communicable may whichever almost disease you name, the endemic ones at least, are all covered under some or the other program. So we have National Vector-Borne Disease Control Program covering 6 diseases caused by vectors, the prevalent ones. We had RNTCP, Revised National TB Control Program, which is now labeled as National TB Elimination Program. Okay, so this is on mission mode now that we have to eliminate TB. Okay, then we of course have National AIDS, Poliomyelitis, Leprosy Program. Most important program, I would say, Universal Immunization Program, because the under 5 mortality rate of India was so high at one point of time, and after the establishment of this program and a high coverage of childhood immunization, the deadly vaccine preventable diseases like diphtheria, pertussis, tetanus, the prevalence has gone down significantly. Non-communicable diseases like blindness, cancer, mental health, stroke, diabetes, every disease has a separate program, and of course newly launched program for palliative care. As the country's needs change, the demands change, new programs are announced. So now we see that we have got chronic diseases, we have got elderly population. That's why probably the program for palliative care. Nutritional programs like vitamin A, anemia, iodine deficiency, midday meal program. The most recent, Anemia Mukt Bharat and Poshan Abhiyan. There are programs for maternal, reproductive and child health like your Child Survival Safe Motherhood, launched in 1972. Then was ICDS, the Integrated Child Development Scheme. Those of you who might have seen Anganwadis, if you happen to happen to visit a village or happen to pay a study visit to Anganwadi. So Anganwadi is the place where this Integrated Child Development Scheme is implemented. The UIP, of course, is related to children. The Reproductive and Child Health, phase 1, phase 2, now labeled as RM, NCH and A. So in that one single head of RM, NCH, A, they have covered the reproductive population, both males, females, the maternal health, ANC, intranatal and PNC, the neonatal health, the child health, as well as the adolescent health. So under one umbrella of RMNCHA, all are covered now. There are specific programs for rural health and development because, as I said, it is the integral part of Indian population. Though the program was previously called National Rural Health Mission, but now it encompasses the entire population, and now the bigger umbrella is called as National Health Mission, right? While the public health was developing all these programs and the guidelines for each disease and etc., the education system, because the public health is at various levels. At primary level, we have our ASHA workers, we have our Anganwadi workers, we have our multipurpose workers at village level, and then at every village we also have, at every 30,000 population, we also have a primary healthcare center. Secondary level, we have a community health center. And finally, for tertiary level, you require something like a district hospital or a medical college which can cater to complicated healthcare issues. You're talking about joint replacement, you're talking about organ transplants. This will not happen in primary and secondary. That's why parallelly it is very important to grow the network of medical colleges in India. And if you see this graph, how much the number of institutes have increased since 1950. Okay, so today, as far as medical colleges are concerned, there are around 710 medical colleges accounting to the tertiary healthcare system. After doing all this, what did we achieve from the, since we got independent and we implemented those many programs and these many schemes, there were so many achievements. The life expectancy of an average Indian was 32 years in 1947 and it jumped to 70 years today. The maternal mortality rate from 2000 to 103 per lakh live births. These are big achievements. There have been eradication of so many diseases and elimination of many. So smallpox has been eradicated. India has eliminated guinea worm also, yaws also, polio, leprosy, maternal and neonatal tetanus, and the list goes on. India is able to contain the diseases like we had SARS, we had avian influenza, H1N1, all were contained. Cholera is brought under control. It was very prevalent at one point of time. It has got under control. And the public health burden of otherwise usual diseases like malaria, if you see 50 years back, the prevalence has significantly decreased. TB has come to mission mode. So these are about your communicable diseases. And for other diseases, now, as I said, our lifestyles are changing. Western adaptation of the lifestyle, sedentary lifestyle, no physical activity, substance abuse, smoking, alcoholism, dietary changes, all these are leading to this lifestyle diseases which I have written in the first line. So this new program now highlights those diseases. Apart from that, India also established the minimum standards for clinical establishment, that is called Clinical Establishment Act. India also revised the Indian Public Health Standards. So how a PHC should be, how a CHC should be. So all these standards have been established. After doing all this, do you think we have achieved it all? Or there are still challenges? So the moment we feel, oh, we have done this, polio done, okay, in next few years, malaria, TB done, but will we be really done? Or there will be new challenges? So always there will be new challenges, new agenda for public health in India. So why this happens? Because there is epidemiological transition from control of infectious communicable diseases. We now have rising burden of chronic non-communicable lifestyle diseases. We are seeing demographic transition. It is good that the life expectancy is increased. However, that means that we have a lot of elderly population to look after, the healthcare and everything. Environmental and climatic changes, no need to explain. And there is still an unfinished agenda of maternal and child mortality. We've come down from 2000 to 103, but when we compare 103 to 1 or 2 per lakh population of developed country, we still have a long way to go. There are silent epidemics. What is increasing? Substance abuse, mental health problems, neurological disorders, because elderly people have more of dementia, more of Alzheimer's. Road traffic accidents are increasing. Also, because of antibiotics and rampant use, irrational use, what is happening is we are getting resistant strains of viruses and bacteria. And also we are getting emerging and re-emerging diseases. That threat is never going to go away. We all in our lifetime probably can vouch that yes, we have seen one pandemic, right? And the financial resources for a populous country like India will never be sufficient. And there is a challenge of bringing equality, right? So in a city, in a say tier 1 city, a developed city of India where one can easily think of, consulting a cardiologist for a minor chest pain. In village, people are still finding it difficult to get a transport to, transfer a pregnant lady who's in labor. So there are two spectrums and a lot of inequality. So these are all the challenges. How to address these challenges? What is the strategy? One wants to have a universal health coverage. The principles of public health or primary healthcare delivery state that it should be equitable. Should be equitable, matlab, there should not be any difference. You are rural or urban. There should not be any difference. You are rich or poor. Okay. So how can this be achieved? How can it be made accessible to all, affordable to all? So the universal health coverage as defined by WHO means all people should have access to full range of quality healthcare services they need, whenever they need it, wherever they need it, without any financial hardships. It is very difficult. It's very difficult in country with so much population. We cannot bring about a public health insurance system. However, there has been a first time effort to do so. So what is the solution? Digital health. Heard of it anytime? Digital health. We hear a lot about digital media, right? And before starting this slide, I would like to say that India is the biggest consumer of the data. So they calculate in those GBs and TBs and whatnot. So India is the biggest consumer of data. We are most active on digital media. So is it good thing or bad thing? It's a good thing that we are used to use the digital resources. Only thing is we need to channelize ourselves, move from the social media, Insta, FB platforms to utilizing this digital media for achieving healthcare. So digital health will be great enabler for delivery of healthcare, right? Some person sitting, some remote area patient who is having query leprosy or any skin lesion for that matter, and he is at least, let's say, 90, 100 kilometers away from a place where a dermatologist is actually having a OPD. Let's say civil hospital or a medical college has dermatologist. But the person is not going to travel for that one skin pad. It is not emergency for him. It is not life-threatening for him, but it needs to be treated. So these are the points where your digital health comes into picture. I have installed X-ray machine, let's say in a primary health center, but I have X-ray technician there, but a radiologist, employing a radiologist in a PHC is difficult. However, if we connect it digitally and provide an interface where the X-ray will be taken there, it will be uploaded, the images will be uploaded, and a person sitting remotely in some other urban hospital is going to report it. So these are the potentials of digital health, and this is how it can support overall universal health coverage. It will integrate the technology, electronic communication in healthcare. So what exactly digital health mean? It is an umbrella term. So where all we can utilize this digital health? First is electronic medical records. So it's a digital version of medical records. So today, let's say if I have a 4-year-old child, and soon he will be due for his 5th year vaccine. Okay? And if I have to go to the pediatrician and the pediatrician asks me about previous records, what if I have lost the file? What if I forget to get the file? What if that paper gets misplaced? So to avoid all this, all the health record of each and every member of India will be digitalized. So these electronic medical records will have vital data from a healthcare provider's chart. So today, even if I'm in Nasik, it will be a unified health interface. And if I have to take my child now for vaccination to some other state, then too it will be possible for that pediatrician to track which all vaccines this child has previously received. Does this child has any allergies? What is the background? Is there any comorbidity? Okay, what medications the child or that patient is on? Everything will be digitalized. Then there is something called telemedicine, which I have already told you in case of skin lesion, in case of X-ray, the examples which I gave you. So telemedicine is providing healthcare to patients where the doctor and patients are not physically sitting together. So it could be over phone or over video call or even by electronic medical records. This is something called as something called as mHealth or mobile health, same as telemedicine, but in mHealth we specifically use the mobile for accessing healthcare services. There are so many apps now wherein people can access healthcare services. And similar to telemedicine, we also can have e-prescriptions, okay, where electronically the prescriptions can be generated based on the patient's symptoms. So that's our future. And from those days of British pre-independence era, today we are in the era of digitization, where Ayushman Bharat Digital Mission is already launched, which will again provide a UHI. UHI means Unified Health Interface. So today, a homework for you and appeal for you all to visit this site of ABDM, Ayushman Bharat Digital Mission, and create your own account there. Then only, see, unless we create our account, we are not going to get benefits. How will we avail the benefits? So first step is every Indian citizen creating his or her own health ID. So this health ID is unique, like we have Aadhaar. So as you know, Aadhaar also faced a lot of speculations. Even this account has faced a lot of speculations, but the blockchain technology which is there in ABDM protects and secures all our data, right? So though it is a unified health interface, unless I give consent on my telephone, say yes, that my data can be shared if I'm showing, my reports to some, or if I'm consulting some other doctor, unless I give consent, that doctor will not be able to access my previous medical records. So what is the first step? What is the first step? First step is to create an health ID. It is called as ABHA, ABHA, which stands for Ayushman Bharat Health Account. So let us not go to whether we are doctors yet. Let us think that we are just an Indian citizen. So our first job is to create health ID or ABHA account number. Second, there are various registries in this ABDM. There is one called as Healthcare Professionals Registry. So very soon, once you pass out, please register yourselves on the ABDM Healthcare Professionals Registry. What are the advantages? You all know these platforms like Practo and Doctor Plus and whatnot, where Google directs you. Suppose I put gastroenterologist near me or a physiotherapist near me. So it channelizes me through Practo that, okay, there is a physiotherapist, but that physiotherapist is the one who has registered on Practo, right? Same, if you want to be visible to people, you have to register on this ABDM's Healthcare Professionals Registry. Of course, this is after you graduate or postgraduate and you have your degree and council registrations in hand, right? Then suppose you have your own hospital, then you can register your hospital also. So suppose I'm traveling, I have my ABDM account and I just search pediatric hospital near me. So again, if you want to make yourselves visible, that facility, that hospital needs to register itself on the ABDM's health facility registry. And finally, the ABDM will have all health records, the public health records. However, no speculations again, its all records will be safe, secure and confidential and will not be disclosed to one another or by one health facility to other health facility, nor there will be misuse, because it is all protected by blockchain technology and without the consent of the actual beneficiary, that is us or any patient, they will not be shared. So this is the current state of India's public health system. With all the national health programs are still in place. However, to reach to the remotest part of Indian citizens, wherever they are residing, digitalization is the new beginning of public health in India. And very soon, as our Honorable Prime Minister always says, heal in India, heal by India. What does that mean? We are having probably the highest, brain source or highest specialist best specialist healthcare practitioners in India. So the world is looking at India as the healthcare hub or medical hub. That's why Heal in India, Heal by India. So that is, if this is the present, that is the future of public health of India. And with that, just a take home message, reflect on this, and then you will understand the importance of public health and importance of comprehensive healthcare. So it is from the book Betrayal of Trust by Laurie Garrett, which says focusing on clinical services, that is curative services, while neglecting the services that reduce exposure, matlab preventive services को neglect किया. It is like mopping up the floor continuously while leaving the tap running. So unless we treat the cause, we are not going to achieve the true health. So with that, my sincere thanks once again to the SIP coordinator, Dr. Rathod sir, and entire MUHS officials, and to you all dear students for your kind and patient listening. Thank you.
First of all, I am very thankful to Dr. Palve madam for such a wonderful session. And I think all students ready for their today's homework. If any student have any questions regarding this session, please raise your hands. Okay, now I request all the students kindly on your video for today's screenshot. Okay, thank you. Thank you, Palve madam.
Thank you so much, Pratibha madam. Thank you all.